bougie slightly and see whether there's some resistance. Yes, there is some resistance. We're at 11 millimeters already, and then I retract it the same way, and if I pull out the bougie already, I can see that the marker is still in the same position, and then you first of all have to hold and fix the wire and see where you have the marker. And you see here, then it's still in the same position. That's very important, so that you know that this wire is positioned correctly, because it's a rather rigid wire, stiff wire, and you obviously want to avoid any sort of damage. What kind of bougies have you used? Well, we've got these one-off bougies, or the disposable ones. So many instruments have become disposable in the meantime, and bougies sometimes are not disposable, but in this case we have disposable bougies by MTV. So the design is identical compared to others, and it's always obviously about the price as well. The question of the price, whether this is something you can go for or not. Now, that much in that context. What about you? The cap? Have you used the cap already? Yeah, we already used the size 12 cap, and that worked well, and now we're already using the 14 gauge cap. And you see that we can really advance really nicely here, no problem. And you see the central hole, and this central hole could also be used for a guide wire here. And then there are two openings on the left and right hand side, and so this is also for air insufflation or for suctioning as well. And now I get down to the stenosis slowly but surely, but you see we can really get through nicely, no big problem with the 14 millimeter cap here. And what you can see nicely with the caps here, well, you already have direct feedback in terms of whether I really have been successful already or not, whether there's some deep laceration, whether I've got to go for another cap or not. So you see, I can still get through really nicely, and that's where we can go for the next step straight away and use the gauge 16 cap. And now we can show you the change of caps. Let's see whether you can see it. Yeah, okay. Now it's like a normal cap, really, and you can glue this on like a normal mucosectomy cap. For different kinds of endoscopes, there's not always an optimum fit, so you could really align the endoscope a little bit, maybe with something else. So you could use normal tape, for example, and line it with that so that the cap shows a better fit. Now, Alex, careful with the time, I have to point out. But anyway, so here we have cap number 16, and we're at the maximum already. So introducing it is not such a big problem. I can really advance nicely. Now, coming to cost and price, I did without the wire, so therefore we could reduce the cost a little bit. But anyway, apart from that, you see we can get through nicely. Alex, you don't hear us, right? Alex? Yeah, so you see there's this little scar, but apparently that's not all that relevant, because I can still use the gauge 16. Do you think you would keep going? Should we keep going? Or when would you stop with your bouginage? Now the abrasion risk really is increased if you go beyond 13, 14, so 16 would be the absolute max, but if it really works well, then the patient should just see how it goes, and then we'll see. Now we are going to inject cortisone here. That's not a panacea, maybe, but still you can maybe achieve some result. Apparently they don't hear us. Yes, we hear you. Yes, we do, but still. That's quite cheeky, isn't it? Anyway, so we've got this third case, the other extreme as it were, so can we just see the introduction here? Right, so in the next case we're going to place stents. And these stents will then open and slip down, and this is what happened in this case. It is a pharyngectomy patient with a gastric polyp for carcinoma, and here you see in this case we already have a stent in place, and now we're going to see what happens to the stent in order to not see it pushed down further. Okay, let's see, can we have the sound here? Okay, now we can hear you. Okay, maybe we can have a look at the X-ray first of all, so that we can introduce the case again. So that's the current position. No, the stent on the X-ray. Now let me show you the stent maybe first of all. So it's a special stent, so you see it is thickly coated so that it doesn't grow into the tissue. That's very important in this case of this stenosis. And here the end of the stent, you see they are folded inwards, so therefore you don't have this this bending outwards of the stent, of the end of the stent, and pressing onto the esophagus. But you see it's composed of these individual elements, independent elements, so you can compress these individually, and this is something that you can then nicely see on the X-ray later on. So with this, obviously we want to avoid dislocation, and that's why we're also going to suture it in place. Okay, that much from the stent studio outside as well. What about the inside? Okay, if we have a look at the endoscopic picture, then you see that's the upper end of the stent. You see the mesh wire here very nicely. We heard about the design already, and I'm using a double canal endoscope, and here you see the suturing device, stitching, overstitch device of Apollo. And here you see the needle, and here you see the suture. And now I would go for the first suture here through the mesh of the stent. So here you see I pull the needle through, wiggle this a little bit, and yeah, let's see. I have to open again. And now here you see the first suture through the mesh of the stent. Well, that's not enough obviously to fix it properly. That's why I'm going to twist this, twist the mucosa. So the needle is then continued over there for a continuous suture. And here you see I try to turn around here in the esophagus. Obviously you don't have that much room compared to the situation in the stomach. But here you see I just suture this to the mucosa. It doesn't have to be a full thickness suture. You don't have to get all that deep compared to the situation in the stomach, for example. Now here you see you have this nice suture from the stent towards the mucosa. And let me finish this. Okay, bear with me for a second. Now here you see the little metal pin. So what used to be my needle before is now the anchor for the suture, to anchor the suture in the tissue on this side first of all, and now let's work on the other side as well. But for this I need sort of a second hand, and Isabella's going to help me with that. Now let's change over this suture. We have to change this now, and that takes some time. And now I'm also going to finish the other side of the suture. Okay, it's really good to work together well with your assistant. Now down here you still see the beginning of this suture, and now you see this small plastic pin, small plastic plug, that's the other end of the anchor or the suture, say. Okay, and now you see this plastic plug down there, and I pull a little bit. I mean, I don't really want this deep down in the tissue, because at one time you might want to remove this stent, then you don't want this to be anchored too deeply and fixed too deeply. Okay, and you see how this withdrew, and now click, and you see that the suture is now in place and everything is finished accordingly. Yeah, that was a really good demonstration of this suturing. Are you going to go to suture it somewhere else as well? Yeah, on the opposing side, and maybe a third suture as well. We'll have to see, but we have to be on the safe side here, obviously.